Good afternoon, everyone. My name is Kevin Phelan, and I'm the nutrition referent from ALIMA, and thrilled to join this session on community-based models of care for neonatal and child health. As we just saw that really wonderful video from the MSF Swiss project in Magaria, Niger. This is really about bringing the tools and the know-how to communities and sometimes into families. So while remarkable achievements have been made in global child health over the past 20 years, today more than 5 million children die every year before their 5th birthday. The leading causes of death for these children are preterm birth complications, pneumonia, birth asphyxia, congenital anomalies, diarrhea, and malaria. And nearly half of these deaths are associated with malnutrition. So the delivery of health services is often weakest where the needs are greatest, and low coverage of the most needed interventions results in a significant unmet need for treatment of these major causes of childhood mortality. We are all pretty familiar with the seasonal burden of many diseases, especially malaria throughout the Sahel, overwhelming health system capacity year in, year out, as well as different contexts of conflict and insecurity that have severe access constraints. In response to this, there is an increasing interest in decentralized models of care involving preventative and curative activities. These community-based packages of care for mothers, newborns, infants, and children are being defined and implemented. In principle, community models of care build upon existing capacity in these communities and strengthens the role of members of those communities as an essential part of the health system. Some examples of packages currently implemented are integrated community case management packages addressing malaria, diarrhea, in some cases pneumonia, and also we'll be hearing in a few minutes about inclusion of treatment of severe acute malnutrition, as well as community-based activities and home-based activities like family MUAC, family planning, as well as community surveillance by community health workers. It's expected that due to the COVID-19 pandemic, the need to decentralize health services will increase even more, and existing community packages may need to see adaptation in their implementation to allow these services at the community level to continue in a safe manner in the context of the COVID-19 outbreak. Evidence exists to confirm that if well implemented, community packages like ICCM can contribute to saving lives of children under 5. However, other studies have shown and exposed various bottlenecks in implementation that can prevent community models of care from having their intended benefit, including poor quality of services. Finally, some studies have shared some lessons learned, how sustainability of community care models can be improved, and how simplified tools can improve the community case management. We'd like to explore these challenges and opportunities in this coming session, with the focus on sharing the lessons learned and solutions that teams have found to existing challenges. So for our first speaker, Dr. Georges Tonamou is the medical coordinator for Niger for Médecins Sans Frontières Swiss section, or OCG, and he will be talking about operationalizing the ICCM program in Niger, of which we just saw the video. Dr. Georges, to you.
Bonjour, mesdames et messieurs, je suis Dr. Georges Tonamou, coordinateur médical Médecins Sans Frontières Suisse au Niger. Le privilège m'a été donné.
Hello, everyone. As you've been said, I'm the medico in Niger, and I've been asked to tell you about the ICCM package that has been implemented in our project in Magaria. Next slide, please. So Magaria is one of the health districts in the southern part of Niger. It covers approximately 760,000 inhabitants, distributed among 5 health areas. It's a hotspot for malaria and malnutrition, high seasonality over 4 to 5 months. Therefore, there is great need in terms of hospital admission for children. For some years now, MSF has already implemented a PEDS unit in the district hospital with a capacity of up to 500 beds during the peak period, with possibility to have up to 800 hospital admissions per week during the peak season. Like in 2020, we were able to welcome 15,200 children under 5 in our facility. Next slide, please. Now, the Megaria project was implemented during the nutrition crisis that affected Niger in 2005, and there was this first the NUT project with 1 CRENI, 7 CRENAS for nutrition recovery and education on an outpatient basis, and then the 7 outpatient clinics for recovery and education was extended. With also extension to pediatrics with the ICCM and a pilot community pilot project. Then between 2018 and 2019, there was also a focus on the community to manage, to have proper management of children's health. And we extended the ICCM to 4 municipalities, 138 villages, with 278 liaison, community liaisons. So the community package is now highly diversified. And we also do a MUAC surveillance. This is done by mother who are properly trained, and there's also peer support. We use what mothers who have the know-how, whom we call light mothers, and you've got also the PFE, which is the Essential Family Program in Niger. Now, ICCM was done in 4 steps. The first step was to select the strategy with district and other partners. We had to select the health areas that were appropriate for the activity, that were eligible, also the eligible villages, i.e. the villages within a radius of 5 kilometers of a health center. We also had to raise the awareness among public authorities, also identify the facilitators and training the trainers at national and regional level. The second step was the implementation proper with awareness of the community, awareness raising activities in the community, also selecting the community liaisons officer with 1 per 500 inhabitants. Then the training of these community officers, also their implementation, the training, supervision, monthly meeting, periodic review with monitoring together with the district. And step 3 was promoting family practices that are essential, what is called PFE in Niger. Also establishing the link with Maman Lumière, with light mothers, and also having activities to promote health. Then step 4, making sure that there was empowerment with an integrated management of diseases such as malaria, diarrhea, pneumonia, malnutrition, plus nutrition screening. Following the implementation of this package, one can see the benefits. It's something which has really improved access to health because it's close to the community. It's also the acceptance level is quite good, and it's free of charge. And people are not waiting for care. And there's also this commitment and empowerment of the community. Community members are now involved more deeply involved in the various steps of the approach, starting with selecting the community liaisons, but also building up everything that is needed. And despite the scarcity of means for these RICOs, for the community relays, the liaisons, they play a very important role. In 2020, more than 50% of patients were seen by a community liaisons, which is quite extraordinary. Now, we can say that ICCM has got a very important impact on access to health, access to care. In 2020, in the health areas where you have ICCM, we can see that malaria was more taken into account. 40% of malaria cases were taken care of. Thanks to that, there's also the fact that 1 child out of 2 is seen by a community liaison for malaria with a rapid diagnostic test that is positive. Now, following the study we carried out in 2020 on this project, we can say that in villages with community liaisons, 44.6% of patients turn to this person for care, and 8.8% self-medicate, as opposed to villages without liaison. 20.5% use community liaison, which means that really these community liaisons are the first access to care and are quite useful. Now, if you look at mortality in the health areas with ICCM, the mortality rate has been almost halved versus the ones without community liaisons, and you can see it's 0.76 versus 1.47. Now, despite the advantages of ICCM, there are challenges we need to face, like scaling up, because the district is very big, and also making sure that quality is ensured, quality and more particularly antibiotics prescriptions, and also making sure that severity signs are captured. And we also follow the data, but these tools to capture the data are very cumbersome. So we would like to simplify them. And also during the winter season, there's a very heavy workload because of malaria. So, and also people have to work in the fields. So, and this is of course important for the families of these community liaisons, and also high performance continuity of care isn't obvious because there are problems of shortages and human resources, and the health centers are not really supported or not robust enough. So it's not easy. We need to have a more reliable source of supply.
Autre défi, c'est surtout
challenge is complying with the safety measures and the social distancing given the COVID-19 pandemic. Another challenge is the education challenge. MSF tends to want to fill the gaps, but there is a risk of by center or at the level of the district. Another challenge is optimizing the healthcare package. Also, how far can we go in decentralizing healthcare provision? Also, there is a risk of increasing the workload, and another challenge is community involvement. In 2020, actually, the community was not involved enough in the monitoring and evaluation of the activities. And in June this year, we will organize community assemblies to foster greater motivation and involvement. Well, ICCM, Integrated Community Case Management, does reinforce and improves access to care. And when the community liaisons, the relays as we call them, are well trained, they're perfectly capable of screening and identifying danger signs and red flags. However, regarding pneumonia, 80% of the children complaining about breathing difficulties are prescribed antibiotics. It's a high percentage, same observation in the health centers. So maybe overprescription of antibiotics. Now, we could improve the healthcare package for the management of malnutrition, but if we simplify our tools, we need a well-adjusted monitoring mechanism. Well, the sites, they do attract people. People go there rather early when they know they can find drugs for free, medicines for free, and where they can be provided healthcare. But we need a better supply chain system for the supplies. We need the right incentives for the community liaisons. Also, we need to prioritize all the inputs for all the sites and the health posts. Now, we're still following the national guidelines for integrated community case management. We have not really innovated yet, but for 2021, we mean to bring some innovations like the frequency of breathing monitoring to improve the outcome of pneumonia. Also, we would like to simplify nutritional protocols, also for seasonal malaria chemioprophylaxis. We would like more people to take charge of the supervision of the treatment administration. So, in conclusion, we do find that ICCM does meet the need of the populations, and it's a real opportunity for the whole community to commit and get engaged and responsible. It's an efficient way to improve the healthcare status of isolated communities, and ICCM has a positive impact on infants and young child mortality rate, which structurally is very high. The model can still be optimized, simplified, and the scaling up is still a challenge that we have to preempt. Also, we want to make it sustainable.
Dr. Georges, very compelling evidence of implementing this program on the ground.